Thank you very much, Ori. It seems like that introduction took up most of the time of my talk, so I'll be... It's always a little bit strange to have those kinds of introductions, but thank you very much. So, grappa. First of all, whenever anybody sees that word, the first thing that they think of is this terrible tasting liqueur. And we have in the midst of the grappa organization a fellow who is always trying to sort of do a little spoof on things, named Philip Hellewell. So I can remember at this meeting we had in New York City in 2003, it was right at the time when the famous electrical blackout occurred in the northeast part of the United States. And so New York City was completely without electricity. And we all were arriving for our kickoff or inaugural meeting of this organization, which didn't have a name yet. So we proceeded with this meeting, and it was actually quite a successful meeting, despite the lack of electricity. I think partly because of it. There was a very high esprit de corps, and some lukewarm beer and pizza that was brought in because there wasn't much food around. And so it was sitting around this that Philip started thinking, well, how can we match the name to grappa? And came up with Group for Research and Assessment of Psoriasis and Psoriatic Arthritis. You'll also hear later on from him about one of his other acronyms called PEST. It's a way of analyzing patients. So we've got a jokester in our midst. But the grappa organization, I think, is a part of the inspiring part of it is the fact that it really is a successful collaboration between two different specialties, dermatology and rheumatology. And I think there are not very many examples where this occurs in medicine, where you have a research and education association that so successfully blends two different disciplines with very different philosophies and approaches to things, but a great interest in each other. And it's now, since 2003, it's grown, and there are now over 500 members from around the world, fairly equally balanced between rheumatology and dermatology, with lots of representation, not only from Europe and some from the Middle East, but also Asia, Latin America, as well as North America. And our goals in grappa are to, initially, were mainly to address the issue of standardizing outcome measures, which we really did not have very good standardization of at the beginning of this last decade when we were starting to do clinical trials in psoriatic arthritis. Now it's devoted to not only development and standardization of outcome measures, but collaborative research in translational science, standardization of clinical registries, learning about comorbidities, and a number of other research and educational activities that I think are really helpful for moving forward the awareness of and our understanding of psoriasis and psoriatic arthritis. So with that background, I'm going to lead off with some points about the cellular and cytokine pathogenesis of these diseases. Understand that I am not a bench scientist. I'm a clinical researcher, but hopefully can translate the science that we've been learning adequately. So we're starting off with a slide developed by Oliver Fitzgerald from Dublin, which is a composite of a number of images which represent the varied and heterogeneous nature of psoriatic disease. In the middle, you see patients with obvious psoriatic plaque, which can be quite disfiguring, which has numerous consequences for the patient, including significant embarrassment and social awkwardness, discomfort, But we now know that patients with psoriasis also have significant comorbidities such as early cardiovascular mortality, which is consistent with its being an inflammatory disease. But it's also characterized by many non-skin manifestations, including musculoskeletal, that are demonstrated in various parts of this slide, including articular manifestations in which the joints can be significantly destroyed, spinal manifestations, the spine and sacroiliac joints. There can be the unusual phenomenon shown in the lower left-hand image of dactylitis, in which a whole digit will become swollen, what we call sausage digit. There can be eye disease, as represented by the uveitis seen in the middle panel above. And as you're going to learn in the next few minutes, the cellular and cytokine influences that lead to these various manifestations are quite distinct, and distinct from other inflammatory diseases such as rheumatoid arthritis. So starting with psoriasis, by the way, can I get a quick show of hands? How many in the room are dermatologists? Okay, a very substantial number. Okay, and how many rheumatologists? Okay, substantial. It's really actually very well balanced. And how about other types of clinicians? Okay, great, okay. Well, good. So for some of those of you that are dermatologists, this is remedial. You obviously know this as a psoriatic plaque. The pathological features we're going to go into in more depth in a moment. But it's basically a hypervascular, hyperproliferative lesion that appears in varying degrees over the body and results in a number of symptoms and signs as listed here. If we look at a histologic slide, on the left you see what appears to be normal skin, and on the right the skin of a patient with psoriasis, in which there is significant proliferation of dermis and epidermis tissue and a thick scale overlying the skin. And this is due to a proliferation and lack of apoptosis of a cell type known as the keratinocyte, as well as a dense infiltrate of lymphocytes and monocytic cells in the dermis and epidermal layers. Theoretically, psoriasis lesions start with either some kind of physical insult or an insult such as an infection or some other unknown factor that leads to activation of dermal dendricytes, dendritic cells, which then proliferate and lead to proliferation of autoreactive T cells. And then this sets up a whole cascade of events that leads to the thickened plaque that we see. Here at a slightly greater detail are some of the key cells that are involved in this, starting with the natural killer T cells, plasmacytoid dendritic cells, all affecting myeloid dendritic cells. Macrophages are involved. These are activated, then leading to lymphocyte activation. We know that both the Th1 or T helper lymphocyte 1 pathway is significantly involved, but also the Th17 pathway. This has been highlighted in recent years, and both lead to the proliferation of the keratinocyte and lack of apoptosis of that cell. And listed here on this slide are a number of the cytokines that are generated by these cells that lead to the messages that lead to activation and proliferation. This is a combination of innate immunity, which is the body's first immune response to external stimuli, and adaptive immunity as well. Here's a more complicated picture that comes from Frank Nestle's recent New England Journal summary about psoriasis pathophysiology and shows the complex interplay between these various cells and the cytokines that are leading to their activation. And again, highlighted here are the roles of the Th1 cell pathway and the Th17 cell pathway, all of which then can be potential targets of therapy, which we'll be talking about as we talk about treatment. Now, if we move over to musculoskeletal tissue, what I've done in this slide is highlight some of the differences between rheumatoid arthritis, psoriatic arthritis, and ankylosing spondylitis. So rheumatoid arthritis is characterized principally by synovitis, that is, proliferation of synovial lining cells, which then lead to the erosive types of changes that we see in bone and cartilage. Ankylosing spondylitis on the far right is characterized by primarily inflammation of bone and the enthesia. Enthesium is wherever ligaments or tendons or joint capsule fibers insert into bone, and it's a unique type of inflammation site that occurs in the spondyloarthritis conditions. And this particularly involves the spine, but sometimes can involve the periphery. In the bone, there are active inflammatory lesions. And psoriatic arthritis we think of as halfway in between these two diseases. So it incorporates some of both. We see significant synovitis leading to destructive changes in bone and cartilage and peripheral joints, but we also see very active enthesitis, where tendons are inserting into bone, both in the periphery of the body as well as the spine. And we also see bone inflammation. And so this is a quite unique phenomenon where in the same patient you can have a predominantly erosive process going on, and in other parts of the body a predominantly osteoproliferative enthesitis bone process going on. Now, if we're going to focus in on a moment on the synovitis and the joints. Here we have a photograph of a patient with psoriatic arthritis. And one of the unique things about psoriatic arthritis is that you can have the various types of pathologies going on in adjacent digits. So on the far right, we see a patient with a finger with the so-called Mutilans variant, in which the proximal interphalangeal joint of that digit is completely destroyed. The bone, the cartilage is gone, and you've got a telescoping digit there. Adjacent to it, the fourth finger on the right, the joint is actually ankylosed. The joint has fused, which is, in many ways, the opposite type of process as what is going on in the fifth finger. There's bony proliferation that has led to the ankylosis. In the third finger, there is the phenomenon of dactylitis, where there is inflammation in the proximal interphalangeal joint, the distal, as well as the metacarpal joint, but also the tendon structures in between, so the whole digit is swollen with inflammation. And in the second finger on the right, there are just two joints with active inflammation. And on the left hand, the second finger is completely normal. So this is unique in its heterogeneity. Here we see it at a radiographic level. In the lower image, we see complete dissolution of bone and cartilage, which is the osteolytic change that leads to the phrase pencil in cup pathology. And in the upper image, we see a periostitis process, a bony formation process that occurs in the digits. Now, at a cellular level, there are some key differences between psoriatic arthritis and rheumatoid arthritis, and key similarities between psoriatic arthritis and ankylosing spondylitis. Now, I don't expect you to read the type. We've photographed this from a journal article or read the type, But the key points that came out in this study that was done by a group in Ghent, Belgium, was to show that samples of synovial lining tissue from rheumatoid patients were all very similar in that they showed a significant proliferation of lymphocytes. There was a significant activity of B lymphocytes and citrullinated proteins. There were germinal centers, and there was not very much vascularity. Whereas in the psoriatic arthritis and spondyloarthritis cases, there was a less of a lymphocyte infiltrate. There was a significant amount of neutrophil infiltrate, which is something that we see more in the innate immune response as compared to the adaptive immune response. And there was a significant vascularity, this tortuous capillary development that you see not only in the synovial tissue, but also the skin of patients with psoriasis, driven by cytokines such as VEGF and Ang2. And this is one of the findings that helps us understand that PSA is in the family of spondyloarthritis conditions and quite distinct from rheumatoid arthritis. Here is an image of the differences in the vascular pattern with rheumatoid arthritis on the right and psoriatic arthritis on the left, showing more tortuous vascularity. Here are images which show significant changes in CD3 T lymphocytes as well as CD68 macrophages before and after an anti-TNF treatment. In this case, it happens to be infliximab, but the same would be apparent with any of the other anti-TNFs. And again, it just emphasizes the significant role of T lymphocytes and macrophages and the changes that occur in those cells with effective treatment. Now, I mentioned earlier that there's a lot of interest in the role of the Th17 cell pathway in this disease, both in psoriasis and in psoriatic arthritis. And here is a cartoon which demonstrates the pathway from a naive T cell to differentiation into a Th1 type cell or Th17 type cell, as well as the Th2 and TGF and TGF beta pathway. So the key cytokines for Th17 cell activation and differentiation include interleukin-6, interleukin-21, interleukin-23, and the key cellular products of Th17 cells include interleukin-17 and interleukin-21 and 22. We're going to come back to that. We do know that Th17 cells are significantly increased in psoriatic arthritis. This is work from Siba Rechaduri and Davis and others that shows us that Th17 and IL-17 are very important in this disease as well as psoriasis. So in summary about the synovitis, we know that there are a variety of processes, innate autoimmune triggers, possibly trauma, possibly the role of bacteria, including the microbiome of the skin and the gut, that may lead to dysregulation of dendritic cells, which then leads to activation of T lymphocytes and the cascade of inflammatory changes that you've been seeing both in the skin and the joints. And that not only the Th1 pathway, but the Th17 cell pathway are highly important here. Now, I alluded earlier to the fact that beyond the skin and the joints, we also can have this interesting and important phenomenon known as enthesitis. Here is depicted a patient with flagrant enthesitis at their Achilles tendon insertion, where you can see actual swelling. This is actually unusual. Usually the patient just complains of pain, or if you palpate the enthesial insertion, they're painful. And you can see in the upper cartoon an inflammatory infiltrate at the site of tendon insertion, and in the lower right, a histologic example from one of the patients in our clinic showing the mononuclear infiltrate at the tendon insertion site. If you look on an MRI scan, here we see a digit of a patient with psoriatic arthritis, and not only is the joint space itself lit up, but also the adjacent bone and the adjacent tendon structures. And all of this light up depicting inflammation will go away with effective therapy. Dennis McGonigal has been characterizing this both by MRI as well as histological sampling, and has developed the concept of the synovial enthesial complex. And in the yellowish is the Achilles tendon inserting into bone, and you see in red a little sliver of synovial tissue, and this is a site of active inflammation. Now, one of the studies that captured quite a bit of attention that was published in 2012 is this study from Sherlock, working in Daniel Qua's lab at Merck Laboratories. And what he did was he took mice, injected them with these mini circles, which were a mechanism for carrying the cytokine IL-23 into the mice. And then with these very careful photomicrograph processes, was able to determine that the IL-23 migrated, many circles migrated particularly to enthesial insertion sites in the animal, as well as the aortic root, which has many tissue features similar to the enthesium. And what was shown was that there was a particular type of T lymphocyte that responded to these IL-23 mini-circles, which was CD3, CD positive, CD4 and CD8 negative, ROR gamma T positive. And this unique group of T lymphocytes then set up an inflammatory response at the enthesial insertion. And it's felt that this is an animal model that may well depict what is going on in the human and represents the key of the inflammatory process there. In this article by Rick Lories, there is also the postulation that when Th17 cells are activated and produce IL-22, that it's the IL-22 that leads to the osteoproliferative phenomenon that we see, thus potentially explaining the conundrum of having an erosive inflammatory process on the one hand immunologically and an osteoproliferative process on the other. How about nail disease? This is part of the standard way in which we look at psoriasis, and this is a person that has particularly grody nails that I'm sure are quite discomforting for the patient. Well, Dennis McGonigal again has looked at this phenomenon at an anatomic level and notes that there are fibers, enthesial fibers, that circumnavigate the distal interphalangeal joint and go up and embrace the nail bed, and hypothesizes that inflammation in this type of tissue may contribute to some of the nail changes that are seen. I've just shown this slide very quickly to indicate the fact that when you look at asymptomatic psoriasis patients, you can often find, when you do advanced imaging such as ultrasound or MRI, changes that are consistent with psoriatic arthritis, suggesting that there may be subclinical manifestations in many patients with psoriasis. Lastly, I'm going to comment on the bone. You've already seen some images of the osteolytic changes as shown on the right. This is the Butylan's variant, which we can see in a proportion of psoriatic arthritis patients with complete destruction of the distal joints. And there's a complex interplay between the skin, the joints, the entheses, and the bone, with activation of certain cells and cytokines in the bone that lead to both the osteoproliferative as well as erosive changes. Chris Richland from Rochester in the US has studied the unusual osteoclast precursor cells in psoriatic arthritis, shown on the left-hand side, where these larger, more activated osteoclasts that are seen as compared to healthy controls. And this is seen more in the erosive form of psoriatic arthritis. Here is other work that has shown us that there's a subtle difference between rheumatoid arthritis and psoriatic arthritis in terms of erosions. On the right, you can see an erosion of the bone adjacent to a joint in psoriatic arthritis, and then the slightly whiter colored is an attempt at osteoproliferative repair that you don't see in rheumatoid arthritis. And then, of course, in the spine, we see examples here of the osteoproliferation of the ankylosis that occurs across vertebra and in the sacroiliac joints. So what we know is going on in these patients are both of the phenomenon shown here, i.e. activation of osteoclast, which lead to bone erosion, as well as activation of osteoblast overfunction by a variety of mechanisms which may lead to new bone formation. Here are depicted three completely different pathways to osteoproliferation through bone morphogenic protein and noggin, the Wnt signaling pathway, and the hedgehog pathway. I like the names that they attribute to these various paths. And all may be potentially going on in patients with PSA and ankylosing spondylitis, and may respond to different forms of treatment approach than the anti-erosive types of treatments, such as the anti-TNFs. And then lastly, I'd like to just comment that there are other features besides the musculoskeletal framework and the skin that may be involved with inflammation, including subclinical gut disease, as well as uveitis. And one of the things we'll hear more about today is the proclivity of these patients to have what we know as the metabolic syndrome, a proclivity to obesity, hyperlipidemia, hypertension, and the consequent problems of early cardiovascular morbidity and mortality. So these are important additional elements to think about when thinking about the pathogenesis of these diseases. So with that, I'll stop and see if there are any questions.